All right. Just hit pause. Welcome to this evening's STROLO-University, our series on CF Practitioner Corner. Just wanted to give a little introduction for STROLO-University, and this program was started in 2020 during the pandemic and quarantine period to help the CF community not only with physical exercise, but also some mental exercise. And we offered a series or several series of classes with exercise and activities to really help with maintaining a positive mindset and balancing the mental health with all the stress and anxiety that we were all dealing with as well. And as this program has evolved into 2021, we have been also offering not only activity and exercise classes, but also some educational and informational and professional classes around career development, research updates, and also conversation with CF doctors around some specific topics. So I'd like to welcome everyone that's on the call with us today. And I will ask that everyone is please to mute yourself during Tom's talk, and then to unmute when Tom is complete, and that if we have any questions that we'd like to share. I would like to also thank our supporter, Nestle Health Science, in making this possible and contributing to the infrastructure of building these online classes. So Tom, thank you very much for joining us this evening. I know you've got a wealth of experience, and were one of my first physicians in transitioning when I lived in Vermont from your care to the adult specialist. And I'm sure in those years, you've faced some questions and challenges, and probably had wonderful advice. So we thank you for sharing your wealth of knowledge with us tonight, but just a quick opportunity for you to introduce yourself.
Sure. Hi, everybody. I'm Tom Lahiri. I'm a pediatric pulmonologist, and I've been the CF Center Director here in Vermont since 2001, which is a long time ago. So and that's when I met Brian, actually, back then. So I've been involved in CFLF for quite some time, and I've been involved in a number of clinical research opportunities nationally and locally throughout the years. CF is definitely one of my areas of interest. And I am looking forward to hearing your questions and having a conversation with you. Brian told me that we're going to focus a little bit on treatment adherence in the kind of era of CFTR modulator therapy, which has been something that's come up quite frequently in our own center here, and I think everywhere in the country pretty much. So I actually just gave a talk on this like about a month ago, just because it's been such a hot topic. And I thought I would just cover a few points first. And I really want to offer this as an opportunity for people to ask questions or have a dialogue about different aspects, because I think we end up learning a lot more from our patients than we might think is actually going on, on the other end. So anyway, so as you all know, there's been a lot happening in terms of the Vertex drugs that have been approved for use in CF, and things culminated in late 2019 with the approval of Tricafta, which is elexacaftor, tezacaftor, ivacaftor, for people with at least one copy of the Delta 508 mutation, and now with a number of other mutations as well. And that looked like an amazing drug in clinical trials, the ones that got published in the New England Journal of Medicine. And we were all cautiously optimistic that this was going to be a real game changer. Many of you may have already been treated with other modulator therapies beforehand, such as either Kalydeco or Orkambi or Symdeko. But this was something different than at least Orkambi or Symdeko was. This is targeting the most common mutation in cystic fibrosis was key. And the changes that were seen in the clinical trial were really dramatic. So most people with CF don't remember actually getting their sweat test done because most people were really young or a baby, but not everybody. And so that's when we measure, how salty your sweat is. And a level over 60 is considered to be abnormal. And then you have to further kind of confirm the diagnosis of cystic fibrosis. And most people who don't have CF at all have a level under 30. And then there's a gray zone of 30 to 60 where you might be a carrier, you might have CF, you might not have CF, and it depends on a lot of other testing that needs to be done. But what this drug Tricafta did is it showed that it could drop that sweat chloride concentration to the normal range for a lot of people, or at least into the gray zone, which meant that things in your cells weren't acting like they had CF anymore. And that's like the key to this combination, this triple combination therapy that's out there. With Delta F508, the channel CFTR itself doesn't actually make it to the membrane of the respiratory epithelium or the gut epithelium or the liver or the pancreas, and it gets degraded inside the cell. And so what Tricafta does is it stabilizes that structure as it's being formed to allow it to get to the surface of the cell. And then one of the other drugs opens it up so that the channel can function normally, which is what kind of the other ones were already doing, like with the other earlier modulator therapies were kind of gating channel therapies to try to open it up. So what else did we see? We saw the chlorides or the sodium chlorides in sweats came way down into like the normal range for many people. We also saw dramatic increases in lung function, on average of 12 or 13% across the board. And with a huge proportion of patients that even responded with more than a 20% improvement of lung function. And then we also saw big increases in weight and improvement in nutritional status. And then I think most importantly, quality of life scores improved for a lot of patients. So there's a standardized questionnaire, the CFQR. Many of you may be familiar with this, may have taken it yourselves, which kind of like rates how people are feeling regarding certain symptoms that they're having. And people that went on Tricafta had these dramatic improvements in how they felt. People noticed instantly within days that they felt initially maybe a little bit more junky, and then they kind of dried up. It felt like there was nothing in there to like cough up for a lot of people. And that people that felt like they could never take a deep breath and would always cough when they did that could suddenly take a deep breath. And exercise tolerance improved, and lots of other kind of great symptom improvements were seen. Also with the GI system too. So with the gut, the secretions are sticky within the CF gut. We know that. And if you correct that channel that's in the gut, more water gets into the gut, it can loosen things up. So you aren't as prone to obstruction, constipation, those types of issues that we typically see. And then I think sinus disease had already been improving a lot, even with the earlier modulator therapies. But again, that was something seen with this. So what doesn't this drug do? What haven't people seen like improvements with? So people who have had, who are older with CF, I think, the expectation was, well, am I going to need my enzymes or not when I go on Tricafta? Because that would be pretty cool if I didn't need to take enzymes. About 15% of people with CF don't have to take enzymes because they have enough pancreatic function to not need that supplementation. But that leaves 85% of people that do need to take them. And I think the reality that people weren't really expecting that to change much. But once your pancreas is scarred down, which happens in about 2/3 of people by the time they're born with CF, like they don't have much of a functioning pancreas that secretes digestive enzymes, is that you're not going to get that back. So permanent changes to certain organs may not improve that much. And we didn't really know to what degree, but there have been some anecdotes and reports of people who kind of had borderline pancreas function and then saw it get better going on modulator therapy like Tricafta. So people who are kind of on the cusp might have a window of improvement. The other kind of like one of the downsides we saw with the pancreas is that, there might be some cells in your pancreas that might be sort of healthy and are just blocked up by the thick secretions. And what we've seen with Tricafta is that some of those people will actually have an irritation of that tissue when they start trying to like pump out more enzymes, and that can cause pancreatitis, which can be pretty serious in some people. And that's kind of like the pancreas's last gasp saying, okay, I can do this. I got a little bit of juice left in me, and let's see if if I can do something again. But, unfortunately, in most people, we don't expect that their pancreatic function will come back. One thing that we have no idea about, and there's a couple of studies looking at this right now. There's a PROMISE study looking at the effects of modulators on different aspects of cystic fibrosis. And then there's the BEGIN study looking actually before people go on Tricafta, what things are going to change, so we're putting babies and little kids on these in these studies to try to see, well, what's your function like now, and how's that going to change when we go on different modulators? So right now we're enrolling people that are going on or can be and these, the kind of earlier modulator therapies, but with the hope that they're going to be moving toward Tricafta. I'd say one thing that comes up a lot in terms of questions that I'm asked is, am I still at risk for getting diabetes from my cystic fibrosis? And I think that's an unanswered question. We don't, if you just look at the timeline of what we're talking about, the first modulator got approved in 2012, and here we are in 2021. And with the best, most highly effective modulator just being on the market for just over a year, basically. So we don't have a track record or long-term follow-up of these drugs to see, well, what's the natural history? I think we suspect that maybe it could delay the onset of CF-related diabetes in some people, especially if they have some residual pancreatic function and allows those cells that produce insulin to stay healthier maybe, and glucagon. But we just don't know. So it's what I tell my patients. I said, we're going to have to wait and see. We still have to screen you and monitor you to make sure you're not developing that problem. But that's one of the big questions that I get a lot, just because that's such a difficult burden for many people to embrace, because it's just like getting another diagnosis on top of a diagnosis that you've already been dealing with. And I think that's really tough for a lot of people. So I think dealing with the diabetes aspect, or that specter hanging over you of like, am I going to get diabetes, is like a great unknown here. The other thing that I wanted to just bring up before I kind of open up to you guys about seeing what you want to talk about is just liver issues with Tricafta and other modulators. So as you know, when you go on a modulator, for that first year, you got to monitor liver function testing every 3 months. And then you go back to annual monitoring if everything looks okay. So we've seen people they're doing great. They feel awesome on Tricafta. Then you check their labs and things aren't so awesome on the inside. Most people are fine, but we've definitely had people in my own clinic, and I've talked to people across the country, where your liver numbers may bump up to levels where people are worried that, maybe there's some injury that could occur if that goes unchecked. So there's a couple of strategies for dealing with that. Oftentimes what we'll do is, like, if the levels are really high, like 5 times above the normal range where they should be, then you just stop the Tricafta. You kind of give it a break, wash it out of your system, see if your levels come back down to normal, and then you make a decision. Well, do we go back to where we were, or do we ramp up the dose a little bit and try to go to like half dosing and then get it back up to the full dose? And we've done it both ways. We have, I think, in our clinic, maybe one person who we haven't been able to really get back on it because of liver issues. But that person's also doing some other, taking some other substances that also affect the liver. And we've been having those discussions about it. So I think it's tricky, like, everybody wants to have as normal a life as possible, but there are some implications to some of these drugs, like that, your body may not be happy if you're on Tricafta and you drink a lot of alcohol, or you do a lot of THC and things like that. And we've seen issues with that along the way. So I think it's figuring out what trade-offs are important to people is kind of the key here. And I'd say the one thing that we kind of thought wasn't going to be a huge problem is that, but it's actually becoming more of an issue, and it kind of like it's a good lead in to just talk about CFLF a little bit, is that people on Tricafta who had been for years and years adding heavy cream to their diet and eating whatever they could get their hands on because they need more calories are suddenly getting very overweight and even obese in some cases. And so we have to say, all of a sudden, after we've been telling you for 10 years, 15 years, 20 years, get those fat calories in, you need that to grow. All of a sudden we're like, you know what? 1% milk might be enough for you. Or maybe we need to like just look at your diet a little bit more carefully and get healthier fats into your diet so that you don't have health problems related to being overweight, which is not usually a big problem in cystic fibrosis, but has become more of a problem over the past year. And we've been seeing that around the country. So that's kind of my preamble to Tricafta as a highly effective modulator. And I'm certainly happy to talk to you guys about any aspect of treatment adherence or not. I guess the one thing I should say is that there is an ongoing study called Simplify, which you may have heard about, where we're trying to look at the effects of withdrawing certain therapies for people who are on Tricafta. And so that would be taking away Dornase alpha or Pulmozyme or hypertonic saline from the regimen, either one of them or both of them, and seeing what happens to lung function and symptoms over a brief period of time, over a couple of months. And so those results are we still have people in that trial right now. And we're hoping that, I think by fall, there'll be some data that's released regarding like, can people take some therapies away? And my personal thought is, it probably depends on what your lung disease was like before you went on Tricafta as to whether we can take some things away, all things away. It really depends. And the great unknown is like, what if we gave these drugs to people who really didn't have any lung disease yet? Like newborn infants with cystic fibrosis who don't have lung disease. They might have a little bit of inflammation, but they don't have structural lung disease. Would we prevent bronchiectasis from ever occurring? Would you even need to do half of these therapies that many of you have had to do for years and years? And that's like, it's pretty interesting. We thought that bronchiectasis meant that it's permanent. It cannot change. It can only get worse. Well, we are learning a little bit that maybe it's not totally like that. Maybe it can get a little bit better. And I've had patients who have had CAT scans that have shown, actually, your lung disease looks better than it did before. It's not necessarily, just stop the progression. There can be some improvement too. And I think that's the exciting part of this for us as people who care for people with cystic fibrosis. All right, I've gone on enough. Why don't I see what you guys want to talk about?
Tom, you're bringing up, thank you for that overview. Really is so eye-opening and like such a practical explanation of it. And I know one of the issues that across the board is a struggle for healthcare providers and clinicians are patients feeling like, great, I'm, almost cured and I don't need all these other treatments, and kind of stopping, making their own decisions to stop treatments with or without discussing it with their care providers. And I'm sure you've come across that in your clinic and in the adult clinic. I'm just wondering, is there any clear rationale that you're able to provide to patients to help their mindset realize the importance of maintaining adherence with their treatment? One thing that I've kind of rationalized with COVID is, here we are into vaccination period and hopefully coming to the tail end of COVID. Now is not the time to take your mask off.
Right.
So that, that's kind of my thought with, treatments is like, why stop preventing what you know works? But I'm curious how your conversations with patients and maybe with the adult care providers has gone.
Yeah, I think there's one thing you just brought up. COVID has had the timing of Tricafta and of COVID is just kind of, it's fortuitous in some ways, and it's ironic in other words. Like, so all of a sudden we had this great drug for people with CF that's going to keep them healthier potentially, and all of a sudden a lot of hospitals shut down across the country saying, don't come to clinic. We're going to do remote visits only. We're going to try to only see people when they need to. We don't want you to come in the hospital, this and that. We've been actually an in-person visit since last spring. We had a very brief period where we stopped, but since last April or May, we've been doing most of our clinic appointments in person when people would agree to do that, if they were comfortable enough to come. Because I do feel like actually depending on what part of the country you are, the hospital might be one of the safer places to be if you're going to go for something, because it's actually pretty deserted right now, because visitations been cut down and everything. So one thing came up with Tricafta. When I'm Tricafta, well, I'm feeling great now. Can I just do remote visits? Well, I think it's trying to make compromises that are not going to cause any harm to the patient is the key here. And right now, if you go to the CFF.org or the CF Foundation website, they are really trying to push to have people maintain quarterly in-person appointments as much as possible for a few reasons. One is we got to do that monitoring that I talked about. So you have to make sure that we're checking laboratory stuff that we have, even if you have a home spirometer, there's some correlation issues between some people's home spirometry and what you do when you're doing a spirometry in the office, even though some places still aren't even doing spirometry because of COVID issues, right now. So we realize that that's an issue, and I'm glad that the CF Foundation is at least getting people home spirometers when possible. The other thing is like, well, there are sometimes, even though a lot of people with CF are really healthy, we do pick up things when we check people out sometimes that you might not feel. So I can hear stuff sometimes in people's lungs where like, I have no symptoms, nothing's going on. And it's like, well, why do I hear this on your right side? That shouldn't be there. That wasn't there 6 months ago. We should look into that more or figure out, do you need an antibiotic? Is there something, even though you feel great, we want to head this off before it becomes a problem. Same thing goes for imaging, like even that we do these surveillance things to try to make sure that you're okay. And I think, the thing that we're just uncomfortable with just saying like, if you're feeling good, just let it go, is we just don't have the track record right now. I think there's a lot of effort to move in that direction because we realize how intense the treatment burden is for an individual with cystic fibrosis. It's one of the most intense diseases or conditions to treat on the patient side. It's just so much work and so much time and so much effort. But what Brian said is true, is that you don't want to take your foot off the gas pedal when you've come so far. And I think we're going to find out that we don't need to do every little thing that we're doing right now, but we don't know what those things are yet. And the way that I tell my patients it's like, okay, your lungs are acting right now like they don't have CF anymore. But there are people that don't have CF that have similar type lung disease that you do. It's called non-CF bronchiectasis. And those people have to do treatments for their lung disease. So except for Pulmozyme, the other stuff is all in the armamentarium. We have people on azithromycin. We have people on hypertonic saline. We have people doing chest PT or vest treatments or airway clearance. All these treatments to try to keep your lungs healthy. And these people don't have CF. They've been tested for CF. They don't have it, but they have a similar type lung disease. So what I've told people, I said, best case scenario is that we turn you into somebody who had cystic fibrosis with bronchiectasis, somebody who has non-cystic fibrosis type bronchiectasis, which is a way more treatable condition where we don't see progression to like end stage lung disease, like we're all used to worrying about with cystic fibrosis forever. Like that's the big concern. Is my lung disease going to get so bad that I can't survive this? And I think hopefully these drugs that have just recently come out and the new ones on the horizon will convert this condition to something that's just that you can maintain and not progress and not die of, really. That's what we want to see. So I'd say that's my approach. It's like, okay, even though your lungs think they don't really have CF anymore, a lot of people have a problem in their lungs, and then we still have to deal with that. I think for people with really mild, minimal, or no demonstrated lung disease, we may find out that you don't have to do nearly as much. But for the vast majority of people out there that are, that are adolescents and adults with cystic fibrosis, that's not the case. So that's my take on it.
Yeah, it's a challenge, especially the issue of some of the multi-resistant bugs, Pseudomonas aeruginosa and Burkholderia cepacia, and people feeling like I don't have congestion, the bugs must be gone, but the reality that they can still be hiding out in the nooks and crannies of your lungs, and I think there's more risk to stopping treatments than is worth the benefit of not doing them.
Yeah, I think one thing from the trials that we didn't see is that the microbiology, so the bacteria that are in your airways, didn't really change that much on Tricafta. So it's not like you have Pseudomonas, now you don't have Pseudomonas because you're on Tricafta. That's not what happened to most people. I've seen that with a couple of people, like they're not culturing it anymore, but it's probably because they're not bringing up sputum anymore. And maybe it's there, we can't find it, but I've done bronchoscopies on people on Tricafta, and I can tell you, it just looks different. Things look healthier, way thinner secretions, and less bacteria in general, less inflammation in general. I see Giorgio had a couple of questions. I just wanted to make sure I addressed that.
Yeah.
So we have a lot of people, Giorgio, I think everybody who qualifies for Tricafta in my clinic is actually on it. And the people that are just about to turn 12, they're going on it like right when they turn 12. So this is a common question. Would you need to take this drug for the rest of your life? So I would say for right now, yes, until something better comes along. And there's a few things that CFF is working on in the Therapeutic Development Network. And that's probably going to be along the lines of gene editing. So where you can actually change the gene in the cell to be a non-CF gene, basically. And so things could function normally. Could that be even a one-time fix if you got that into the cells? So it's not something you have to do every day. That's kind of where the technology is going. We're not there yet, but they've shown in certain models that they can get this into cells. CRISPR-Cas9, if you've heard of that, that's like the buzzword. It means that it's a way of editing genes and putting in what they call wild type copies, so non-mutated copies of genes into cells so that your body won't manifest as having cystic fibrosis. Again, people who already are on enzymes and stuff like that, you're not going to regenerate organs probably because of that, but it could totally be a game changer for the lung or for other organs that aren't as affected, and that's probably what the big pie in the sky is right now. That's what people are really kind of looking at as what's on the horizon, what could really change my life without like, oh my gosh, I missed my Tricafta dose. When's my next dose due? And then if I don't take it for 2 days, a lot of people, even if they miss their Tricafta for 2 or 3 days, they feel different. They already feel junkier. They don't feel as good. It's really amazing how quickly it happens. So in the trial, they showed within 2 weeks, people had these amazing changes. And I've seen people in 3 days have those changes. We just happen to see them in clinic 3 days after they started the drug and their numbers are up. And it doesn't happen to everybody, but it can go down just as fast. So it's like one of those critical, oh, I'm feeling awesome, maybe I'll take a break. Well, it doesn't really work that way at this point because you need to have constantly have that in your system for it to act on the channel, because the channels don't stay there. They turn over constantly. And to have them continue to like be normal, you need to keep taking the medication. But it's tempting, I think, for a lot of people who've been just suffering with a lot of symptoms for a long time to say, well, you know what, I'm in a different place right now and I can do whatever, I want. And we see that a lot. And we try to, cautiously advise people to like talk to us if you're thinking about changing what you're doing. Maybe we can find some common ground and say like, hey, that makes sense. We'll try one thing at a time. I know some people I've had in the Simplify trial that stopped pulmozyme and hypertonic saline. They're like, we're done with the trial. What do we do now? We feel great. Our lung function didn't change. And I think everybody that I've had do that has been like, I don't really feel comfortable doing nothing, and I'm like, neither do I. So why don't we pick one that you feel is like the one that you would less mind doing and do one of those treatments right now. And we'll just keep monitoring it really closely until either you're experiencing any symptoms, we see some changes, or we get the results from the study that give us more information about what's going on.
Mhm. Yeah, it's amazing that the landscape of treatment options and advancement that has occurred, just in my lifetime. And I remember when I was age 13 and the CF gene being fully mapped, and news reports saying that a cure was potentially on the 5-year horizon, and that 5-year horizon kept going out 5 years, out 5 years, out 5 years. But I remember on that day of hearing the news before school, eating a bowl of breakfast, a bowl of cereal, committing to myself, I can hang on 5 years, and I'm going to do everything in my power to stay healthy enough, long enough to see a cure in my lifetime. And I think, when it comes back to the work of the CF Foundation, there's, that balance of treatments that will keep us healthy enough, long enough to see the cure in our lifetimes. And again, just kind of coming back to that element of like the burden of treatment versus the benefit of treatment. And really, I think what has always driven me, both treatment wise and exercise wise, has been anxiety about getting sick, about early mortality. And, there was value in that anxiety that always drove me. But part of the mental health benefit I'm finding in Tricafta is a lot of that anxiety has significantly lessened, almost evaporated. And so it's taking a different drive that I'm having to really dig up to force my own self to maintain my treatment schedule, and to consciously make a decision to go exercise, as opposed to having this little nuclear power plant of anxiety to drive me. But I'm curious, Tom. One of the issues that we've discussed within CFLF and our support of people's access to exercise and active lifestyles is the impact of Tricafta on people's mindsets. And will patients feel more so like, this is great, I have this new lung function and I can exercise so more, versus my lungs are stable even without exercise, and being quarantined over the past year has kind of demonstrated that to me, where I haven't been able to exercise and I've maintained stable lung health. So I'm curious your take on Tricafta's impact on lifestyle, and whether it's like enabling people to feel as though they can slack, or more opportunity to push themselves even harder.
Okay. Yeah, I'm happy to address that. Also, there was a question in the chat about when they check blood for Tricafta, what are we looking for? It's really all our markers of liver inflammation for those quarterly ones. So if you're a pediatric patient, you'll have to have your eyes checked annually too, to look for cataract formation. That hasn't been shown to be a problem in adults. And then for everybody, looking at liver function tests. And most people don't have symptoms with that either, which is why it takes a blood test. So people won't have necessarily a bellyache or an enlarged liver. They have signs that their liver is injured in some way. And so that's what we're looking for, is inflammation or injury to the liver. In terms of the exercise piece, I think, again, this whole COVID pandemic and the advent of Tricafta are just interesting in terms of how it's affected that. Because even for my patients who don't have CF, who I see, many of them are much less active than they've ever been, just because they're isolated, they can't go to school, they can't do this and that, they're stuck in the house, people are uncomfortable going out into different settings. And so they're getting kind of out of shape, they're getting overweight, their asthma is getting worse as a result because there is a link between weight and asthma severity. And with CF, I think we're still in that honeymoon period of, we're only a year into Tricafta basically, and it's awesome, but people in general with CF haven't been exposed to the stuff that they normally are exposed to. So most of the viruses that we normally would be getting sick with, most people haven't been seeing at all. Very few people with CF have actually gotten even COVID. If you look at that, we've had a bunch lately and they've all actually handled it great. Nobody's gone in the hospital at all. Just because it's in the community and younger people now than it was ever before. But I actually have used exercise as a way of talking about treatments with patients. It's like, okay, you're doing awesome. Like some people say, like, I feel like I can do more and I want to do more, and I'm like, well, you always could do more. Like I have people that have had 100% or 110% predicted lung function say my CF is limiting me. And I'm like, well, it's not really, you have symptoms related to it, but your lungs are probably as good as, who's the guy sitting next to you who doesn't have CF. And this is a helpful strategy for trying to move those secretions around. It's still true. And now I think it's even probably more important that some of those negative lifestyle changes from not moving around are going to start to manifest themselves in CF. So people who worries about like getting heart disease and CF, I can eat whatever I want. I can do whatever I want. I don't have to worry about getting a heart attack, because I'm overweight or whatever. Well, that's not true anymore. I think, and people are living so much longer with CF that you have to protect yourself if you want to live kind of a long and healthy life. And we know that exercise turns around a lot of those metabolic issues and will, strengthen your heart health, for instance, and actually make your physiologic age younger than what your chronologic age actually is if you're really fit and you do exercise. So those are like really important, I think. But I think and I've talked to some people like, oh, I've been doing a vest twice a day and I want to do this and that. I'm on Tricafta, I do this. So I was like, well, you know what? Let's make your exercise plan why don't you do 30 minutes of this, keeping your heart rate at X or Y, or where it's in the aerobic range at least, and do one vest, like that. And we've kind of made compromises that way too. And I think we've had discussions about that all along. I think when you have really thick CF secretions in your lungs, exercise is definitely helpful, but it isn't a total replacement for airway clearance for most people. But there's differences in opinion on that. There's a lot of different, if you go to Europe, you'll get a totally different take on what should be done for airway clearance and what should be done for exercise. They're all in on exercise and not so much on kind of mechanical airway clearance stuff. So if you go to Scandinavia, it'd be like, nope, you got to jump around for 30 minutes a day if you're a 5-year-old kid. And that's going to be your airway clearance, which I think is great because it gets you that lifestyle early on, which we try to instill in families. But if the parents aren't really doing that, it's hard to get the kids to be the only ones doing that. And so I think it's a whole different approach to care. Brian brings up a really interesting thought here. What are your thoughts, experiences of people post-transplant and Tricafta? So this has come up a lot. So because right now Tricafta is not approved for people who have had lung transplants or liver transplants for that matter. There's a lot of concern about liver transplants, about creating inflammation in a transplanted liver, even if it might help out your lung. So I think right now there is a group looking at this issue. I would be hesitant to use it in a liver transplant recipient, even if they have lung disease related to CF. I think there's too many interactions with other drugs. If you're a transplant recipient, you're on so many different medications that could potentially interact with Tricafta that I would worry that either your levels would be too high or too low. I think for people who've had a lung transplant, there really isn't as much of a role for Tricafta, because if you're already on enzymes, like I said before, we don't think you're going to come off enzymes. Could it keep other parts of like if you have a lot of sinus disease, I guess post-lung transplant, would it help that? It probably would, but we just don't know if the trade-off is worth it right now. So I think transplant is a really tricky area. We haven't made as many gains in post-transplant care over the past decade as we have in other aspects of CF. So I think that one's a tough one to say. Right now, I'm not advocating that they approve it for people with transplant, because I think they need to like look at this really closely to see the safety aspect of it. And they may be doing a trial at some point. The problem is like, it's about 200 people with CF every year get a lung transplant. So the numbers aren't huge. And to try to like study that problem is difficult. And then everybody's got different issues with transplant. So not everybody has the same complications or the same course post-transplant that might make it more or less doable. So that's those are kind of issues that I see with transplant and Tricafta.
Tom, that kind of triggered some other thoughts of for people that have shown some significant lung function improvement. Have there been any correlations with sinus issues, sinus polyp development? And likewise, for people that have found some improvement with digestive processes and maybe less need for enzymes, has there been any note of improvement with CF-related diabetes management and need for less insulin?
I'd say for the sinus disease, it's across the board with any of the modulators. It gets better if you look at the whole population. And that I think a lot of the ear, nose, and throat surgeons who would have to see CF patients frequently aren't needing to see them nearly as much, because it definitely helps the sinus disease and nasal disease and polyp development, probably just from keeping things thinner up there. Not everybody is going to have that response, but most people would. In terms of the gut, we see a lot of people that don't need Miralax anymore because they can go more easily, or they don't need, a really heavy gut regimen to be on. So that's really commonly reported right now. I think the diabetes thing is still a bit of a black box. By the time you have CF-related diabetes, some people that are on insulin do still have some basal insulin production. And if you can improve that by freeing up that part of your pancreas, so to speak, with modulators, that you might see insulin needs go down. You might also see insulin needs go down because you're just healthier. So people who have less inflammation, less infection might have lower insulin needs anyway. But I haven't seen anybody come off insulin that's been on insulin with Tricafta. And some people are really still struggling. I have people that are really struggling with their diabetes management on Tricafta like they were before. And it hasn't changed any of that. And that worries me, just because diabetes, has a lot of long-term consequences if you're not able to keep it in check. Just like people who don't have CF with diabetes, there's a lot of problems with your circulation, with your eyesight, with your kidneys that, can sneak up on people over years, which is why it's such a tricky problem to manage and a really important problem to get under control.
Yeah, another great point that you make, that the impact of Tricafta on lifestyle and being able to exercise more or wanting to exercise more, how that affects blood sugar levels and glucose needs.
I definitely talk to my diabetic patients even more. I mean, we talk about exercise with everybody, but we know that if you regularly exercise and you're diabetic, your insulin needs are different, right, than they are when you don't. Like we see that when people are sick and they come in the hospital, all of a sudden they're needing all this more insulin because, their insulin needs change, I should say, like just because their sugars are running higher because they're not burning off as much in terms of what their body's doing.
Yeah, pre-pandemic, I had just gone through some issues where I was not exercising as much, and then began exercising again. And so my insulin needs went pretty significantly down. And then as pandemic set in and quarantine, I was exercising less. So my insulin needs went back up. And now even, as things are reopening up and I'm starting to exercise more, it's kind of this like roller coaster that you have to be really careful with lifestyle and insulin, that you're not letting yourself go too low because you're taking too much insulin all of a sudden.
And Tiffany said when she started Tricafta, didn't need as much insulin as usual, but now I need more than before. Like I said, it is a bit of a roller coaster, like Brian was just saying, that your body, when you're not as inflamed or infection isn't really popping up, that might give you a period where things are okay. But depending on what's going on with the rest of you, and some people, like I said, may put on more weight and need more insulin because of that. There might be other issues. We don't really understand it yet, but once your pancreas kind of like needs insulin replacement, it's a hard thing to totally come back from. And I think we don't know that. There might be some people, I haven't heard of people yet that have been like, oh, I needed insulin, now I don't because I'm on Tricafta. I haven't heard that yet, but that could have happened to some people depending on where they were. I think the other thing is like, there's been a lot that's happened with diabetes management that's been really helpful for people with CF who have diabetes. And those are like those continuous glucose monitors and closed loop systems where it's reading your blood sugar and spitting out more insulin into your system, all kind of like in kind of a smoother way, where all you're really then responsible is like, how many carbs did I just eat or drink, and putting those in. And if people do that really well, we've seen like blood sugar control like come under amazing control really fast if people are actually doing the carb entering correctly. So I've definitely seen that be a huge innovation, even though it has nothing to do with CF. It wasn't made for CF, it was made for type 1 diabetics. But hopefully people with CF will benefit from those things too.
Wow, we've covered a lot, Tom.
Yeah, other questions for anybody, or anybody want to talk or chat?
This has been absolutely wonderful. And I think,
Tiffany, I saw you unmuted. Did you want to ask a question or anything?
I was like trying to think of one before that got back to me.
All right. You guys think of stuff afterwards and you let Brian know, like you can get stuff to me. I'm happy to kind of feedback to you guys if you have other questions that you're thinking about. It's not a problem.
that's wonderful. Well, thank you so much, Tom, for your time and your expertise. It looks like Giorgio.
Yeah, I had a question too.
Yeah.
So that's a big question, Giorgio, because everybody's a little different, right? So not everybody, I can't give a expected weight. Is that we generally see that BMI, so body mass index, and weight improve on Tricafta, but it's definitely not the same for everybody. I've had people gain literally 50 pounds. I've had people gain 5 pounds. And it really depends on what's going on with your body in general, where kind of your CF is at, where other issues with your health are at, and what your diet is like too. It has a huge amount to do with that. So I think it's tough. I wish I could just say, oh yeah, you're just going to gain 10 pounds. It's going to take 4 months and that's what's going to happen. But I don't think anybody has that answer yet. And I just don't think there's so many factors that go into nutrition that I think when we talk about, Giorgio, when we talk about people improving their weight, we're looking at the whole population of people with CF. So obviously that means not everybody will do that, but the majority of people will have these changes. I'd say the one last thing on Tricafta is that unlike all the other studies that were done with Tricafta, where usually like with Orkambi or Symdeko, you would see, wow, like a bunch of people had 10% improvement in lung function. A bunch of people had 5% improvement. A bunch of people had 10% decreases in lung function or 15% decreases in lung function, but the majority got a little bit better. So it was like a 5% improvement. With Tricafta, we didn't see that. We didn't see the negative side of things. People either stayed where they were or they got better. And almost in the trial, it was like almost to a person. So that kind of gave everybody a lot more confidence that this was going to be beneficial to most people who qualify for that drug. The other thing that we don't have treatments for right now, and I think that the CF Foundation is actively working on, is people with class 1 mutations. or what are called nonsense or missense mutations, there are no modulators for that right now. So unless you happen to have a copy of a class 2 like Delta 508 or something that Kalydeco can treat, there's no modulator treatments for about 7% of the population with CF. And I think that's an active area because nobody wants to leave those people behind either. And obviously, if I take 7%, that's like of people who qualify. So there's a lot of young people that don't qualify for modulator therapy yet just because of their age. And hopefully they will soon as the age comes down.
Yeah, and I know we have another session in one of our series coming up on talking about some of the mRNA treatment developments that are in clinical trial. And I think that's going to be a really interesting conversation as mRNA has been such an active role in COVID.
Yeah, it's in the media quite commonly now, right? So that's all we're hearing about, right?
Yeah, so it doesn't seem as Star Trek in the future as we once thought.
No. And I hope you guys are all able to get your vaccines. That's or have hopefully received them or getting them soon if you haven't.
Absolutely, yeah. It was a trial to get to, but I think people with CF are probably amongst the most tenacious that I know. So
yeah,
absolutely. Well, thank you again, Tom. This really has been tremendous. I know we're just coming up on our hour, and I want to respect your time and appreciate everyone that's participated on the call this evening, and anyone that has been able to watch through Facebook or Facebook Live, please feel free to share this video or like it. And again, thank you to Nestle Health Science for your support of this ongoing program. As we continue classes through this semester, we'll be through the end of May, and we'll be looking to build topics for another semester this coming fall. So we're always open to suggestion and inquiry about what other topics people want to hear about. But thank you again, Tom, and look forward to talking with you soon. And hopefully we'll get to maybe see a Champs Challenge in Vermont.
Yeah, that'd be nice.
This year.
Well, everybody have a great evening and have a healthy year, okay? Everybody, we'll get through this. Okay, bye, guys.
Absolutely.
Thanks.
You too. Thanks again.
Bye.
All right. Bye-bye. Have a good night.